A very good afternoon to all the PGDGM students, academic counselors, program in charges and the regional directors. I welcome you for this teleconferencing session. We will be discussing genitourinary problems in the first session and the gynecological problems in the elderly in the second session. And before we start, I would like to introduce our guests today in the studio. To my right is Dr. Kamala Ganesh. She is retired professor and head of department of gynecology in Maulana Azad Medical College. She has been associated from this PGDGM program right from the beginning. She has been involved in writing, in editing, as well as she is now a regional consultant in Delhi, and she has given us a guidance in all the various issues while planning and implementing the program. I welcome you, ma'am, for this session. To our left, we have Dr. Anuradha. She is the assistant professor in medicine in Maulana Azad Medical College in the Department of Medicine. She is also an academic counselor for the PGDGM batch in Maulana Azad Medical College, and she has she takes a very active part. You must have seen her many times for our teleconferencing sessions, and she is also involved in various other activities like assignment preparation, checking of papers and all that. So I welcome you also.
Thank you. Thank you, Dr.
Now, we all know that genitourinary problems are one of the very, very important problems with which the elderly may present as such, or in a multiple disease complex. When the elderly present themselves to any healthcare provider, they have problems where genitourinary problems also coexist. So these are the problems which may come out during the history, or they may be one of the main complaints with which the patients come to us, and there are many times in which there are a lot of reasons, underlying reasons for the similar kind of causes. So I think it is important for us to understand the reasons why these genitourinary complaints come up, and how to tackle, how to diagnose, and how to manage these problems. So I would request Dr. Anuradha to begin with what are the changes which occur in the genitourinary tract which result in the various problems, complaints, and the symptoms which are associated with the genitourinary tract.
Thank you, Dr. Ruchika. We will first very briefly discuss what are the various kind of changes that occur in the elderly patients that are responsible for some of these diseases or disorders that are seen in the elderly. Some of them are structural changes, some of them are functional changes, some of them are changes because of endocrine abnormalities that occur with aging, and some are associated with the natural process of aging. All of these in combination, or maybe one of them which could be more prominent, could result in one of these following complaints. If we talk about the genitourinary tract changes that are associated with aging, the first is there can be a loss of muscle tone in the bladder and the ureters. This lack of muscle tone can lead to urinary retention, which is quite a common problem, especially in elderly males. Once there is urinary retention, there is residual urine which gets left in the bladder, and this urine can then get infected, and it can be a cause for the recurrent urinary tract infections that can occur with these patients. Another thing in the contrast would be that there could be a decrease in the bladder capacity and a decrease in the relaxation ability of the bladder. So because of this reduction in the bladder capacity, many elderly subjects, this is actually quite a normal physiology which occurs in these patients, and we find that most elderly subjects do get up at night to pass urine, and this nighttime evacuation or nighttime elimination of urine or nocturia is because of this reduced capacity of the bladder to hold urine. There can also be polyuria or excessive urination, again as one of the components of this decreased bladder capacity. Although we are not talking in great detail about the renal function derangements or nephrological aspects today, but fewer functional nephrons in these patients, declining function of the present nephrons, a slowing of the glomerular filtration rate, and a reduction in the blood flow to the kidneys that occurs with normal aging puts elderly patients at risk for renal failure. This is the normal physiological changes that occur during aging. In addition to this, there could be other changes, like for example, if patients are taking drugs, they could be nephrotoxic and they could further compromise renal function. But this is the basic physiology which occurs as normal process of aging and is one of the risk factors that can produce renal failure in these patients. Elderlies are also at a higher risk for infections because of many mechanical changes. Like I said, structural changes could be there, and this alteration of mechanical barriers acts as a focus from which infection can then spread on and can even lead to very severe sepsis in these patients. There are changes in kidney structure and function. There is a relaxation of the female pelvic floor which reduces the bladder emptying capacity, and there is also collection of residual urine, and all three together compound to act as a potential source for urinary tract infections. In the males, there is a loss of the bactericidal prostatic secretion as aging progresses. There are alterations in the urinary bladder mucosal lining. There is a loss of phagocytic cells. There is a decrease in the secretory IgA which is there, which again puts the bladder epithelium at higher risk for development of infections. There can be alteration of normal mechanical barrier. For example, there could be some other reason for which an elderly patient is admitted, and during the episode of unconsciousness, if there was urinary drainage catheter which was inserted, that drainage catheter leads to a disruption of the normal mechanical membrane barrier, and this disruption puts the patient at very high risk for developing subsequent urinary tract infections. Associated with this are certain post-menopausal changes that occur in the urinary epithelium and the urogenital epithelium in females. There can be atrophic vagina and atrophic vaginitis, and this is one of the major factors which can lead to repeated colonization, and this repeated colonization may in turn lead to urinary tract infections. The presence of urethral strictures, neurogenic bladder, prostatic hypertrophy, all these act as potential sources of bladder outlet obstruction, and the presence of bladder outlet obstruction again leads to collection of residual urine, and this again accounts for increased episodes of urinary tract infections in these patients.
Before we go on to urinary infections, yes, I would like that you discuss urinary incontinence, because that I think is most common. I think even Dr. Ganesh would agree that
yes,
it is probably the most common.
As a matter of fact, once one of our seniors used to tell me that if you ask 100 women to stand in a row above the age of 60 years and ask them to bend, you will find 90% of them will have incontinence, which they might not admit in the initial stage, but if you examine their pads, you will find that the 90% will have some amount of incontinence in them.
Yes,
it's a major problem.
It is a major problem. It's a problem which most women do not admit to, because they find it very embarrassing to actually tell about the problem, talk about the problem. They feel that it is normally which is occurring to them as part of aging, and there is no treatment for it. It's a very big misunderstanding and a big myth that urinary incontinence cannot be taken care of. It can be taken care of by very simple, even non-surgical means are sometimes enough to take care of these problems. But the most important point is to recognize that it is there, to come out, to tell the doctor that the patient is actually having the problem, and to detect it and then institute appropriate management for it. So when we talk about urinary incontinence, there are different types of urinary incontinence that are there, and the most important of them, if we see the statistics worldwide, it is said that 15 to 40% of women over the age of 60 in the community report incontinence. Ma'am, was Dr. Ganesh just said, almost 90% of them will have some incontinence, though they may not report it. This is the incidence of reported incontinence, that is the complaint with which the subject is actually coming to a doctor. So almost more than 50% of women in nursing homes are incontinent. So incontinence is a very major problem among the elderly females. WHO in fact has recognized incontinence as an international health concern. It is recognized as a major problem which these women are facing. They are not actually talking about it, they are not telling about it, and we need to recognize and do something to make these patients feel much better. There are certain myths that are there in regarding to urinary incontinence. The first is that urinary incontinence or a prolapse is a natural part of aging. It will occur to everybody and anybody, and nothing can be done about it, or surgery is the only solution. It is not true. Neither of these three statements are true. We need to recognize this and we need to take care of this. What actually causes urinary incontinence or urogenital incontinence is that there is a concept of urogenital aging. It's a symptom complex associated with the physical findings, and basically it involves the lower urinary and the genital tracts and the pelvic floor. It is these abnormalities in the pelvic floor muscles which actually are responsible for development of urinary incontinence. The symptoms of urinary aging actually are frequency, that is an increased frequency of urination; nocturia, that is getting up at night repeatedly to pass urine; dysuria could also be a feature, meaning there is painful micturition. There is a sense of incomplete emptying, in the sense patients complain that they have evacuated the bladder but they still feel the need to pass urine. There could be incontinence, which could be very severe. There could be urgency, recurrent infections, dyspareunia and prolapse. The biggest problem is that all these have a very severe negative impact on the quality of life. The impact on the lifestyle and avoidance of activities. Many times we find elderly women they always say, I cannot go for long journeys because I feel I will need to pass urine and there will be no place where I can pass urine. So I will go only for short duration of journeys. They have a lot of problems in sitting in the cars or traveling in buses for long durations, where it is difficult for them to find a place where they can get down and pass urine. They tend to avoid some jobs or some other things, activities, which they feel that it will lead to incontinence, and then they completely avoid their friend circles. They have always a fear of completely losing bladder control. They will fear that over a period of time this incontinence is going to get so bad that I am going to be completely incontinent all the time, and that is a very severe, affects their psyche in a very bad way. It causes a lot of embarrassment to these women, and in fact it is this embarrassment that prevents these women to complain or bring this complaint to attention to their physicians in the first place, or even to their attendants or caregivers. They find it so embarrassing and humiliating to tell or talk about the fact that when they cough or sneeze, they actually are incontinent. It is a big problem. They don't accept it. They feel that society will not accept them because they are having it. Because of there is an impact on relationships. Naturally, if they are incontinent, they feel that they tend to get increasingly dependent on the caregivers, and that is not something that they would like to do. They'd like to maintain a degree of independence, and it feels as if a part of their independence has gone. And of course, because of repeated incontinence, there can be discomfort, skin irritation. It can give rise to local skin problems that can be there. If we talk about the types of urinary incontinence, one of the commonest is stress incontinence. There is also urge incontinence, mixed incontinence. There is overflow incontinence because of chronic urinary retention. There can be functional incontinence, and there can be various miscellaneous other causes where urinary tract incontinence can be there. Let us talk about stress incontinence. What stress incontinence means is that there is a leak of urine with increase in abdominal pressure. It is basically caused by a pelvic floor damage or weakness, or a weakness of the urethral sphincters. So what happens is, whenever there is an increase in the abdominal pressure, for example, there is laughing, coughing, sneezing, running, lifting heavy weights, walking. Whenever the patient or the elderly subject actually does anything which increases the abdominal pressure, there is a leak of urine. A few drops of urine leak out, especially when patients laugh loudly, sneeze, or even cough loudly. And that is a complaint with which patients are actually very embarrassed. The primary cause is a descent of the bladder neck below the pelvic floor, and any actions that cause, like coughing, sneezing, laughing, like I said, or even walking, that strains or stresses the abdomen will allow this urine to leak, causing incontinence.
Over here, I would just like to ask Dr. Ganesh that, because as you have also mentioned that it is more common in the females.
Yes.
Now, what is the reason that, because of course she has said that because of the damage or weakness of the sphincters. Now, what is the reason for the weakening of the sphincters, especially in the females?
Childbirth injuries causes the nerve damage, especially of the internal sphincter, and it can also damage the external sphincter because of the pelvic floor muscle damage. And if at that time, if it is not repaired properly, some amount of weakness may remain, which may not exhibit in the reproductive age group, because the other coping mechanisms like estrogen, presence of estrogens and all, strengthen the muscles. Now when those muscles also become weak due to estrogen deficiency as well as due to the aging process per se, then the symptoms becomes more evident.
Is it the childbirth per se, or is it the use of instruments like forceps?
Not necessarily. Even the normal childbirth can cause some amount of damage. It can be there, and that is the fascia and the muscle supporting the pelvic floor, which supports the uterus, the urethra, the vagina. So it can cause damage to that.
So are there any preventive or curative mechanisms so that
we can. What we can do is, during the time of childbirth, proper childbirth care must be taken. That they should not push before the cervix is fully dilated, and if at all any injuries are there, the injuries should be stitched properly. Then postnatal exercises will tone up the muscles, and repeated childbirths can be avoided, like having 8 babies, 10 babies and all can be avoided. So using contraceptives will also help to some extent. They should have only the number of children that they want, not any extra. So all these will help in reducing the childbirth injuries.
Thank you.
Now, actually, like Dr. Ganesh said, these are injuries which occur in adulthood and don't manifest till late, till the time that the pelvic floor actually becomes weak because of the normal process of aging. So when that problem starts compounding the childbirth injury which has occurred in adulthood, it is then that the problem actually starts manifesting.
Exactly. And the other myth that is to be understood by everybody is there are ways by which the incontinence can be managed.
Yes.
And it is not always necessary that a surgical procedure is required, and there are so many ways it can be managed. And even for diagnosis, if you take a proper history and a thorough examination, will help you to diagnose what sort of incontinence it is present and how it can be managed.
Yes.
So sophisticated investigations
are not required. In fact, actually these require very simple bedside clinical skills to just elicit. You have to ask the patient very simply, when you cough or sneeze or strain, does urine trickle down? It's a very simple question to ask, which patient should respond, and you should be able to find out what is going on. We were talking about stress incontinence. Let's talk about urge incontinence. And urge incontinence is when there is, can I have this slide please? Yes, urge incontinence occurs when there is a leak in the urine due to an involuntary bladder spasm. So involuntarily the bladder contracts or has a spasm and there is a leak in urine. That can be associated with detrusor overactivity or a decreased compliance of the detrusor muscle. The basic complaints in this group of patients would be their urgency, frequency, and what happens is inability of to reach the toilet in time. They say, by the time I feel the urge to, when I have the urge to pass urine, I can't even control my urine till I reach the toilet, and by that time I become incontinent and I soil my clothes. So that is what is urge incontinence. In stress incontinence, it was whenever there was an increase in abdominal pressure, the urine used to leak. In this situation, the subject needs to pass urine but cannot actually hold on to the urine till such time the patient can actually go to a place and void it.
Now, what are the causes for the urge incontinence?
Urge incontinence, as Anuradha rightly pointed out, that usually the bladder has got two. The continence mechanism of bladder is because that the bladder can accumulate the urine to a large extent, and even when the urge to pass urine comes, that urge can be overcome and they can accumulate further urine in the bladder without causing any intravesical pressure. And the intraurethral pressure is always more than the intravesical pressure during this bladder filling phase. And this raised intrauteral pressure is helped by the presence of hormone, the estrogen, which causes the vascularity to increase, and they cause a urethral coaptation, mucosal coaptation. Now this gets lost in the elderly because of the lack of the estrogen. Of course, there are the voluntary muscles becomes weak, which keeps the urethra in a state where the urethral pressure is more than the vesical pressure. And during the process of voiding, then due to the various stimulation, cortical stimulations and all, and the voluntary relaxation of the urethral external sphincter, then the bladder contracts and the voiding takes place. So that is how it is, and in the process of aging and due to hormone deficiency these occur. And in the urge incontinence, during the filling phase, there are bladder contractions, and these bladder contractions causes the pressure to rise and the urine has to be passed. So the urge becomes more and they have to void urine, otherwise they will not be able to hold it.
So this has nothing to do with childbirth in the...
No, this has nothing to do with childbirth.
This is
due to aging as well as neurological contraction, involuntary contraction of the bladder, due to the woman may be neurologically normal otherwise, but if you do a cystometry in such cases, you will find the bladder contractions are present, and you will find.
And also urinary tract infections further contribute to urge incontinence. In fact, sometimes one of the presentations of repeated urinary tract infections could be just
even a bladder stone, a bladder diverticula, a tumor, bladder tumor can cause this
urge incontinence. And then there are patients in whom we have the other category of incontinence, where there is a combination of both stress incontinence and urge incontinence. And that's also quite commonly seen as called mixed incontinence, where patients will have symptoms of both. That they will also have the urge incontinence, and in between, when they have increased abdominal pressures, they will have stress incontinence.
See, one has to remember that now one symptom is caused by one problem. A problem may have 2-3 types of urinary symptoms. So a combination of symptoms and the way they present, the way the start of the problems, all these things will help in arriving at a diagnosis, and it will help us to manage the problem.
At this moment, I would also like to request the studio people to kindly flash the phone numbers and the fax numbers, because I think there may be a lot of questions that the students would like to ask concerning about the various types of incontinence, and while we are discussing it, I think it would be useful if you, any questions that you have, or any patients that you have come across with such kind of problems and you would like to share, you can always share at this moment with the rest of the viewers, and we can discuss such case studies. So, can you please flash the numbers, please? You can continue.
Another type of incontinence is overflow incontinence. By overflow incontinence, it means that the bladder keeps on collecting urine to a level beyond which it cannot hold the urine. It reaches its maximum bladder capacity, and then because of that, there is an overflow of urine. And one of the common causes of overflow incontinence, especially in males, is bladder neck obstruction because of prostatic hypertrophy. So it starts with complaints of obstructive symptoms in these patients, but later on, if it is untreated, unrecognized, the bladder may remain persistently full, and after beyond a period of time, then there develops overflow incontinence. Previous bladder neck surgery, because of maybe patient has had a BHP in the past, was operated, the operation was not, surgery was not successful, that could also be there. Certain neurological disorders can also give rise to chronic retention, and we need to take care of that in case patient is having some other neurological problem. Always, we must never forget that antidepressants, for example, tricyclic antidepressants, have a very potent bladder relaxation ability, and so they can cause retention of urine. And in a patient who already has prostatic symptoms, we need to be very careful before we put these patients on tricyclic antidepressants or other drugs which can give rise to urinary incontinence. Then there is another concept which is known as functional and transient incontinence. This is not a very well defined entity, but it's very functional and transient in nature. It's usually seen in the elderly patients during a time of urinary tract infection. During this episode of urinary tract infection, there is increased bladder contractility, there can be urge incontinence, there can be because of restricted mobility. For example, if a patient is unconscious because of any other particular problem, has a neurological problem, has meningitis, during an episode has pneumonia, is unconscious for a period of time. So transiently during that period of time, patient may be incontinent. That is not related to the genitourinary tract per se, but has an influence because of a central nervous system abnormality. So we need to be very careful. Another important cause, though in this situation it will probably not be transient, could be a psychological or cognitive deficiency. We find that patients who are having Alzheimer's disease, patients who are having other neurodegenerative disorders, later on always tend to be incontinent, and then they will be continuously incontinent in such situations. When we come to treatment of incontinence, Dr. Ganesh has already stressed the fact that we must remember that it is not always surgical. There are medications which are there which help to strengthen the urethra. There are medications if we find that the bladder is not relaxing. There are medications which can help relax the bladder. There are also physical exercises which can be done to strengthen the pelvic floor, which are very simple to follow. There are certain very simple rules which patients can do. Patients can avoid caffeine, fluid, alcohol, especially in the evenings and nights. What this will do is this will reduce the amount of urine which patient will need to pass in the night, and so it may prevent the need to urinate frequently. Patients should be given bladder training, in the sense regular voiding by the clock. The subject should be asked that, okay, every 3 hours he gets up, he voids and he comes back. So in the sense, the bladder needs to be retrained in these patients. Gradually over a period of time, yes, please.
Now in this connection I would like to point out there is something called maintaining a urinary diary, and that urinary diary will help you to find out how much fluid the woman is consuming, how many times she is passing urine, that is the frequency, and how many episodes of incontinence she had during a daytime. So if she keeps it for 48 hours, a diary, it will help you in the diagnosis. On that basis you can even plan the bladder training.
Yes.
How she should go about it, and where she is taking more fluids in the evening, it can be curtailed.
Yes.
The behavioral changes are brought about.
Yes.
And then there are some women who are always scared that, oh, if I don't go now, I'll leak.
Yes.
There will be a leakage of urine. So if you tell them the diary, and if they maintain it for 2 days, and after that the bladder training is given, and they keep a diary for a day even, they can find out the difference that it has made, and it gives them confidence and they can do better.
And these are very simple techniques and very simple things that need to be done. You just need to adjust your lifestyle a little bit, consume less fluids at night, do minimal pelvic exercises which strengthen the pelvic floor, get up regularly to void so that your bladder is empty by the time you are sleeping at night. So these are very simple. These hardly cost anything. They don't require expensive tests. They don't require any exhaustive investigations. These are very simple techniques which can be done in addition to drugs which can really help the patient.
And I would like to add one more thing here. There are, since these people are elderly people, they have problems. They may be already on medication. There are medications which are going to cause incontinence, or they are going to relax the urethral relaxation. There are some which cause urinary retention.
Yes.
So the advantage can be taken of these drugs, and those drugs which are going to aggravate the problem, we should not use them in these women.
Yes.
An alternate medication has to be given. But in those women where the drugs are going to help, these drugs can be used. So it is very important to take the history, drug use, and we can use the drugs according to the advantage of the patient.
Few drugs which you can mention maybe, like antihypertensive,
antihypertensive, diuretics, then anti-cough preparations, antidepressants. So there are so many preparations.
Yes.
The list is given in your module.
Yes. So when we talk about the other non-surgical methods, one is of course physiotherapy. We have to advise strengthening exercises to the pelvis, to strengthen the pelvic floors, and that can be very, very helpful in addition to bladder training. In patients whom atrophic vaginitis is a major problem, then you can talk about either systemic hormone replacement therapy. I'm sure Dr. Ganesh will talk about it briefly, and also you can have local application of vaginal creams in case you find that this is the factor that is actually contributing to the problem. Then when we want to talk about drugs to decrease detrusor activity, that is in patients who are having severe urge incontinence, you want to decrease the detrusor activity, there are certain muscarinic antagonists which can be given. For example, propantheline, flavoxate, oxybutynin, tolterodine. These are available in India. They can be very easily prescribed to these patients, and they can have very significant impact on the on the incontinence in these patients. But we need to remember that they have a narrow therapeutic index. What it means is that if prescribed in very large doses or uncontrolled, they can have very significant systemic toxicity, which could include dry mouth, blurred visions, constipation. They can even induce drowsiness in these patients. So you need to be very careful that your patient actually is suffering from increased detrusor activity or actually has urge incontinence, and only then prescribe these with careful monitoring of these patients. Of course, there are surgical interventions that are there for stress incontinence. We need not go into the details, but there are many different kinds of surgeries that are there for these patients, and it can be done in situations where it is very distressful, it is causing a lot of problems to the patient, and it is directly relating to a lot of morbidity in these patients. So you can select that group of patients where you actually need to go through with them. So I would like to summarize about incontinence, talking that you should find out whether it is stress incontinence, whether it is urge incontinence, whether there is mixed pattern, or whether it is caused by some other central nervous system abnormality or a cognitive abnormality. So the management depends upon what kind of incontinence you are dealing with. All patients do not need to undergo surgery. You can very effectively treat patients by behavior modification, lifestyle modifications, by few physiotherapy exercises and appropriate use of drugs. In most patients, you should be able to achieve good control of incontinence with these very simple techniques and maneuvers that are there.
I think we can come to urinary tract infection now, because we've discussed, I think, quite a bit on urinary incontinence, but UTI again is one of the problems which may be one of the main complaints, or may just crop up during the other symptoms or as an investigation.
You're absolutely right. It is one of the most common complaints with common infections which is seen in the elderly. Patients may present with very classical symptoms and signs of urinary tract infections, or they may just present even with unconsciousness because of severe sepsis because of an ascending urinary tract infection. So we need to be very careful as to the diagnosis and management of urinary tract infections. Like I said, urinary tract infections are the most common infections, bacterial infections, that are encountered in the older population. The diagnosis and treatment can be challenging, especially in those patients who are in long-term care units, because what happens is these patients who are in nursing homes, patients who are having cognitive disabilities, these patients will need to be catheterized on a long term, and since they are catheterized for such a long term, they will recurrently develop urinary tract infection. It is something that cannot be avoided, and so management of these patients is extremely challenging. It's a very difficult situation in this. As elderly population increases, the female to male ratio of UTI narrows down, approaching 2:1. You find more and more pathogens, but most commonly what you find are E. coli and gram-negative organisms are the most common.
So we have a call from Hyderabad. Yes, Hyderabad, please come in.
We are very curious to know the classification that you have given, the differential diagnosis of the module is different from what is already being discussed here. Functional and transient and mixed, these things are not there in this thing. You just fit in this detrusor hyperdyslexia, detrusor sphincter dysenergia, what is it you are curious to know?
Okay, thank you for your question. You can identify yourself.
Okay, what he was saying is that it is not reflected in the module as these kind of terms. Okay, detrusor hyperreflexia or detrusor increased activity would actually mean urge incontinence. Problems with the stress incontinence would be because of decreased pelvic floor regulation, or problems with the internal urinary urethral sphincter. Actually, in the module it is given.
No, in the module, hyperreflexia is reflected, that any urinary problem caused due to neurological problems like Parkinson's, multiple sclerosis, those are written as urinary.
Actually, the mechanisms which is there in the module is more physiology related. What is happening and what is causing the kind of incontinence. The classification that is generally followed, or what the one I just showed you on the screen, is the one that is more clinical, and that is the way you actually go about finding it out, whether it is stress, whether it is urge incontinence, whether it is a mixed pattern, whether it is occurring in patients who are having neurological problems. The bladder hyperreflexia and the other kinds which are mentioned in the module are basically the physiological underlying aspect of the different kinds of incontinence. So I think it is the same thing, but only thing it's seeming to clash because of the fact that it's classified in different manners, because it's physiology there and it is actually the clinical manifestations That is the way it is classified here. I think that should solve the problem in these patients.
Yeah, I think I'd just like to add here that see, in the morning also, in fact, we were discussing the same thing, that during the teleconferencing sessions, we do not always just restrict ourselves to the module. We do discuss things which may be related to the day-to-day life or day-to-day practice that you are having in relation to the subjects that are discussed in the module. But from the examination point of view, whatever classifications are given in your module have to be stuck to, because the module is the one which is being followed by the examiners. So basically in the teleconferencing sessions, we'll give you a different perspective also, so that you are aware about, you know, what are the various other aspects for the same problem, and you can discuss it vis-a-vis your daily day-to-day practice and your associations. So I hope what Dr. Anuradha has discussed concerning the various classifications has been understood. If still there is certain misunderstanding or clarification required, then we can take care of that.
There is a fax from Jabalpur.
Okay, we have another fax from Jabalpur. They just said that there are 7 students who are attending the regional center Jabalpur. I would like to thank the assistant regional director for the information. Thank you.
So continuing on urinary tract infections, there are certain factors in the elderly subject that actually put them at higher risk or promote these patients from developing urinary tract infections. Many of these are directly age related. For example, increasing age itself is one of the risk factors. Menopause and its hormonal abnormalities that occurs is another. Instrumentation of urinary tract. Many times elderly subjects come in for some other problem. They are catheterized for a very brief period of time, and even that brief period of catheterization is actually significant enough to cause problems later on. Dehydration. If patients continue to be dehydrated for long periods of time, many comorbid interventions, illnesses and interventions to manage bladder voiding, many of these can actually promote urinary tract infection. Other risk factors are atrophic urethritis and vaginitis, benign hypertrophy of the prostate, which leads to increased residual urinary volume and which acts as a source or a nidus where the bacteria can actually overgrow, CA prostate, catheter use, genitourinary abnormalities, for example vesicorectal fistulas which can develop, calculi, other abscess formations, urinary procedures, urethral strictures which can develop in males. All these things are put the elderly patients at a higher risk for development of urinary tract infections.
I'd like to ask you, Dr. Anuradha, here that we know that in the younger age group, especially in children, UTI is more common in the females. But what about elderly? Is that also more common in females, or because we know that prostatic hypertrophy also takes place, and then there is retention and more chances probably.
Well, yes, you're right that in the sense that in young adults, urinary tract infections is actually very uncommon in young males. It is common in females, especially who are in the reproductive age group. It's quite common
even
in them.
Even in the children,
yes.
It is the females.
But as age increases, the proportion of men who have UTIs also increase. But still, the female preponderance continues even in elderly age. Though the disparity between male and females may not be so significantly different as it is in the younger population. In the younger population, if a young adult male has a urinary tract infection, it almost invariably it is in fact taken as a cause of secondary UTI. It is not even taken as a primary UTI. So it is always taken that there is some underlying source or pathology or functional aberration which is there, which needs to be investigated. That is not so true in elderly patients. Elderly males can develop urinary tract infections, especially if they have benign hypertrophy of the prostatic or urethral strictures which can develop in these patients.
But I would also like to ask Dr. Ganesh that, ma'am, in what are the type of symptoms that the women in the postmenopausal present? Out of those symptoms, how common is UTI?
See, UTI is recurrent urinary tract infection in the gynecological practice itself is a means many women come for recurrent urinary tract infection, and this is due to the atrophy caused by the estrogen deficiency along with atrophic vaginitis. The lower urinary epithelium is squamous epithelium which also gets atrophied, and because of that the urinary tract infection is very common. And you can find that there is a gaping of the urethral epithelium which causes formation of caruncle, because the gaping causes the urethra goes inside into the vaginal cavity, and that causes the infection and formation of urethral caruncle. and the repeated urinary tract infection has to be treated by giving some amount of hormones and strengthening the epithelium of the lower urethra as well as the vagina, and then treating the infection. And means my practice is that when these women come, I tell them, I don't give them systemic hormones, I give them local estrogen hormone, that is the Evolon cream or estradiol cream. The Evolon cream is available in our country. I ask them to use it every day for the symptoms disappear. Then I give them a maintenance dose of once or twice a week, and they have to use it throughout their life. And then the urinary tract infection is treated at that time with the appropriate antibiotic. And I tell them, even if you are cured, if you don't have any symptom, continue with the estrogen cream. And in addition, I change the pH of the urine every 4 to 6 months, that by alternate alkalinization of the urine, so that the organisms doesn't grow. So every 4 months or 6 months I tell them, take alkali once, means 3 weeks, with a gap of 1 week in between. So this keeps them, I find that my patients are quite happy with this treatment.
When we talk about the presentations of urinary tract infection, many times these elderly women or males may actually be completely asymptomatic, and during an investigation or for something else they have come, you find you do a urine examination and examination shows field full of pus cells. So patients will be either completely asymptomatic, or they may present with very classical features that are there, that is fever, there could be urgency, there can be burning micturition, hesitancy and dysuria. Many times, and it's very important to remember this, many times patients may have atypical presentations. For example, there can be alteration in mental status, there can be abdominal pain, suprapubic tenderness, and in these situations a very high degree of suspicion is required to detect and diagnose urinary tract infections. Management of urinary tract infections remains the same whether it is an elderly patient or it is an adult, and that is you have to do a urine analysis, which is a urine microscopy, a culture and sensitivity. Depending upon your sensitivity pattern, you need to administer appropriate antibiotics, treat and identify any other underlying condition. For example, if a patient has benign hypertrophy of the prostate, you need to take care of that because this patient is going to come with recurrent UTIs. If a patient has atrophic vaginitis, like we were discussing briefly earlier, we need to take care of that, otherwise it is going to contribute to it. And of course, patients who are already catheterized and are on long-term catheters, it is extremely difficult to manage urinary tract infection in these patients, and these patients can have actually a lot of problems in the management of urinary tract infections.
Now there is a question.
We can take the question, I think, because we want to finish prostate in 2 minutes. If we can finish prostate,
yes,
then we can take this in the next session.
Okay. When we talk about disease, when we are talking about genitourinary tract diseases, one of the common diseases that occurs, especially in males, is diseases of the prostate. And if you see among all types of prostatic diseases that occur in males, 80% of them are because of benign prostatic hypertrophy, about 12% of them are prostatic cancers, and 2% of them are prostatitis or inflammation of the prostate. And there is an investigation which one must know that is called prostate specific antigen and PSA, and it is very specific biological marker for prostatic cancers.
I think we can begin with the symptoms and just discuss the management.
Okay. When we talk about benign prostatic hypertrophy, it's usually an insidious continuous condition, and there are triggers during which there can be many problems which can give. It can either have very classical obstructive symptoms in which dysuria, there is a difficulty in initiating a urinary stream, there is a weakened stream, the patient needs to push to urinate, increased time to emptying the bladder, terminal dribbling, retention, all these can be. And these are the very classical obstructive symptoms. Patients can also present with irritative symptoms, that are daytime polyuria, nocturia, and urgency in urination, incomplete voiding. So both kind of symptoms, both obstructive as well as irritative, can be there. Very simple examination technique to diagnose is a digital rectal examination or a per-rectal examination. You can find the size, you can see the surface and see for the consistency. You can even make out whether or not there is an abnormality or irregularity or nodularity of surface which could indicate or point towards a suspicion of a prostatic cancer. Treatment All patients need not undergo surgery at the first time you diagnose benign prostatic hypertrophy. You can have a grateful watching type of situation. You can again prescribe conditions or alter lifestyle by which you can delay the need or delay the progression. Medical treatment is indicated in uncomplicated conditions. It can slow the progression of benign hypertrophy of prostate and delay the need for surgery. Classical treatments that we give are doctor
I think treatment and all is being covered already in this, but I think one of the more important things that I would like to discuss here is, I think benign prostatic hypertrophy begins in the middle age. The symptoms come in the middle age, so whatever diagnosis has to be made starts in the middle age and it just progresses in the
yes,
isn't it?
Usually symptoms usually start, or even the problem or the prostatic hypertrophy actually starts somewhere towards late middle age or adulthood. Yes, and by the time patients come to you with these classic symptoms, they are well into geriatric population. So if we can, and these are so subtle early on, it is very difficult to recognize this problem in the initial stages. So if we can actually find out the problem at the initial stages and tackle it well, so I think you can delay it, or you can delay the progression of the disease. And there are very simple things by which you can do. You don't need to do anything very dramatic about it.
So I think I would like to thank both of you, because we discussed the two major problems that are faced by the geriatric population. One is urinary incontinence and the other is UTI. Of course, we have touched upon prostate, but I think they are very classical symptoms which are easily recognizable, and in case there are any questions on prostate, we would like to take up in the next session, and we have a question from Jabalpur which also we will take in the next session. So any more questions, kindly fax us during the break time. We have a 15 minutes break and we will be joining you at 3:30 now to discuss the gynecological problems in the elderly. Thank you.